Mr State.
Good morning, my lady. The first witness today, please, is Daniel Mortimer. Could he please be sworn?
I do solemnly,
sincerely and truly,
declare and affirm
that the evidence I shall give
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you. Could you give the court your full name, please?
My name is Daniel Joseph Mortimer.
Thank you. You very helpfully provided a witness statement to the inquiry, the reference for which is INQ 000513763. It's 54 pages long and dated the 21st of November 2024. Is that statement true to the best of your knowledge and belief?
It is.
Thank you very much. By way of background, you are the Deputy Chief Executive of the NHS Confederation and the CEO of NHS Employers, which is part of the Confederation. Is that right?
That is correct.
You held that position through the pandemic and, in fact, were the interim CEO of NHS Confederation between October 2020 and June of 2021. Is that right?
That is right, yes.
Thank you. And as CEO of NHS Employers, you say you have an understanding of how COVID-19 impacted the NHS workforce. Can I ask you, please, just by way of brief background, what is the NHS Confederation and what is NHS Employers?
Of course. The NHS Confederation is a membership organisation. It represents the whole range of organisations that commission and deliver healthcare in England, but also in Wales and Northern Ireland. It's a charity. And its role as a membership organisation is to support our members, but also to act as their advocates and their representatives, particularly with government, but also with the public. The Confederation also delivers some services on behalf of the Department of Health and Social Care and other arm's-length bodies as well. NHS Employers is the largest of those. There are others as well. And NHS Employers is the employers' organisation for the NHS in England. It has a particular role in representing what is the largest employer in the country to government, but it also delivers some services on behalf of the Secretary of State and the wider NHS. And we have a particular responsibility for supporting the management of the relationship with trade unions in its various forms.
Thank you. You say at one point in your statement that the members you represent employ some 1.5 million staff, care for more than 1 million patients a day, and control 150 billion of public expenditure each year.
Yes.
So a significant voice forum within the NHS. Is that a fair summary?
We aim to be so, yes.
Thank you. In terms of your work, the work of the NHS Confederation during the pandemic, did this include collecting insights from members about the reality on the ground?
Yes, our particular role, or one of our particular roles in the pandemic, was to collect those insights, but also to amplify them and to reinforce them with the government, various arm's-length body organisations.
Could you give us an idea of those types of bodies? I think you mentioned people like NHS England, DHSC, but also others.
So we particularly dealt with DHSC and NHS England across the range of issues, but we also had interactions with Public Health England, as I think I referenced in my statement, Number 10 and the Cabinet Office in terms of their particular interest in how services might be resumed after the pandemic. We interacted with regulators, so people like the General Medical Council, the Nursing and Midwifery Council, and also less frequently people like the Care Quality Commission, the CQC. And similar conversations were replicated in Wales and Northern Ireland by my colleague.
Thank you. As I'm quite sure you're aware, the inquiry has heard a fair bit of evidence about PPE, quality, fit, and so forth. And the focus of my questions is really about, as much as we can, issues relating to procurement and distribution. Looking at your witness statement, can we turn to paragraph 100, where you talk about personal protective equipment and its distribution? You say the availability and suitability of PPE was, quote, the dominant theme of the first phase of the pandemic. Does that mean the dominant theme of the feedback you were receiving, the insights you were receiving from your members?
Yes, absolutely.
And in what way do you say that it was the adequacy and availability and suitability of PPE? How did it feature in that theme?
So there were several factors at play. I think the first is every part of the health service, and as well as our colleagues in social care, were reporting a lack of availability of PPE. That was particularly reinforced by certain parts of our sector. So there was a perception by our members, particularly outside of hospitals, that yes, there was availability issues everywhere, but they were particularly challenged in GP surgeries, community settings, mental health services. That's the first thing. I think the second thing is there was a particular concern about the availability of particular equipment. So concerns around masks fitted with respirators, visors and goggles. There was a particular concern around the availability of equipment that could fit different types of faces, whether that was because of gender differences or because of ethnic minority or religious observance issues. And there was also a concern that is referenced in the statement, and I think we quote people from the service indeed, that actually there was an interaction between the guidance and what felt like fairly constant changes to the guidance around PPE and availability. And indeed, there was some disagreements about guidance. So in particular around aerosol generating procedures and what were and weren't aerosol generating procedures. And that both drove concern and anxiety, but it also drove demand for particular types of kit, particularly masks with respirators, FFP3 masks, irrespective of the guidance.
One issue you raise in your statement is that it was felt by members, I think, that the national approach to PPE was felt to be focused on the acute sector.
Yes.
And in relation to that, you say this: some members were able to secure local suppliers. You give an example of Manchester. But then you say those local arrangements were effectively nationalised. In other words, local suppliers producing PPE to be shipped across the country, which meant there was often, your members were telling you, less available locally than there had been before. Is there anything you can say about that aspect?
So there's two things. I mean, I think in that initial phase of the pandemic, lots of organisations, probably even most organisations in the health service, had to talk to other businesses that used PPE, particularly face masks and gowns. And we give examples of that as well in the statement. But in particular, a number of organisations were able to find manufacturers who switched from, and I think the case in Manchester was switched from manufacturing clothing to manufacturing PPE. And in the kind of May time, a communication came out from NHS England, DHSC, that the more significant kind of local arrangements, local production arrangements in particular, actually had to be made available for national supply. There was a concern that Manchester may have found a solution, but a different part of the country was still facing real challenges and didn't have the kind of manufacturing facility that colleagues in Manchester were able to find. And those changes, and we raised that in particular with NHS England and DHSC in May, and members spoke to them, I think, in June. That switch from local to national was a real concern for people because they obviously would suddenly they feared they would have less available for their people, their teams.
You say this in your statement: new national procurement and distribution arrangements in England were rapidly designed and implemented for reasons I'm sure we can understand. But in terms of the feeling of your members, you say, but that frustrated our members by being initially unreliable, leaving some of them powerless to resolve supply issues at a local level. Why is it, do you think, and in terms of the feedback, why is it that your members were seeking to resolve things at the local level? Was there a greater confidence in that, or was it a necessity?
So clearly, I think members understood, we understood that the colleagues who were working at pace in fairly unprecedented times on this issue were doing their absolute best. But people, both in the initial phase, gained confidence from their ability to source things locally. And in the slightly later phase, and these phases were matters of weeks, as I know you will know, actually the national system wasn't giving them what they needed. So the message very much was, and people understood, the national system was scaling up at real pace. But the so-called push system wasn't necessarily giving people what they expected, and they were still having to supplement locally. So in that first phase, they had no choice but to contact local businesses and get hold of equipment. But in that later phase, when there was a much more developed national system or multiple national systems, they were still having to supplement the national with local. And in the example that we previously discussed in Manchester, there was a fear that in those kind of examples, actually that was being diverted to the national rather than helping the local. And these are not abstract things. These are leaders, general practitioner leaders who weren't able or were worried they wouldn't be able to provide equipment to their staff who were treating patients, that they wouldn't be able to properly protect their staff from contracting the virus. And that's, that was at the heart of all of this.
Another issue you raise in relation to this is that NHS procurement rules sometimes stood in the way of opportunities. And an example you give was enabling the use of PPE stock held by commercial organisations in their geographical area in the hospital setting, rather than waiting for the central system to procure and distribute.
So the issues that were being raised were particularly where people did find a manufacturer or some alternative supply, but it didn't necessarily meet the CE certification or whatever it may be that was required. And that ability to rapidly deploy alternative sources of equipment, again, in those first couple of phases was really important. It was picked up at a later date. We published something for members, I think it was in 2022, with NHS Supply Chain. And within NHS Supply Chain's kind of altered arrangements, there is something that acknowledges that they have had to put in place something that can rapidly identify and source alternatives and accredit alternatives. And that wasn't, at least in our members' experience, that wasn't available or easily available in those early phases of 5 years ago.
This was, you tell us at paragraph 104, something which your organisation contacted NHS procurement about, addressing, as you say, the challenges of innovations in PPE not being able to get into the NHS market due to a lack of CE certification. Did you, as an organisation, support... What was your position in relation to CE certification?
I think what we wanted to make sure, and I think we spelt this out in correspondence at other times, is we wanted to make sure that whatever system was required to set the standards, to protect staff, protect patients, could be deployed as quickly and as simply as possible. And the concern that we were getting, to my understanding, was that wasn't the case, that people were being told they couldn't, people were felt they couldn't innovate, couldn't source alternatives quickly because the rules wouldn't let them do it. So it was a plea for the rules to be simplified and to be made more accessible and more rapidly deployable.
Is that something now, reflecting on matters, that you think has happened?
I mean, our experience, as I've said, with supply chain is that they have put in place a mechanism to identify and support alternatives if there's a problem with the kind of the preferred supply, and that seems a really sensible step to take, and that has been tested in one or two areas where there have been supply problems post-Brexit, post the war in Ukraine. And that's proven to be effective. Nowhere near the scale of what we were facing 5 years ago, but nonetheless, we've seen the benefit of that.
In terms of the impact of lack of supply, this is your paragraph 102, you talk about your members describing being unable to plan for surgical procedures due to a lack of access to necessary PPE, being unable to assure the safety of their staff, primary care members having to rely on local shops, beauty and tattoo parlours to access PPE.
Yes.
At times having to crowdfund for their equipment.
Yes.
And you say that these issues about inadequacy of availability were raised throughout 2020. What was the impact in terms of trust and confidence, or in terms of anything else on staff, was the feedback you were receiving?
There was a profound anxiety. As I've said, at the heart of this was the desire of leaders in organisations and trusts, leaders in primary care facilities, to protect their people. So there was an absolute sense of anxiety. There was a sense of a lack of confidence, which only magnified that anxiety. There was a lack of confidence both in the supply but also the guidance. There were particular areas of concern. I think it became very clear in the early part of the pandemic that black and minority ethnic staff were being disproportionately impacted by coronavirus, disproportionately represented in terms of fatalities in particular. And in the April, that was a real area of concern. And again, that was both about total availability, but also about the availability of appropriate equipment, or equipment that was most appropriate for the range of staff that we benefit from having in the health service. But yes, at its heart, it was about profound anxiety and a profound understanding of the risk that frontline staff were facing and were placing themselves in terms of caring for patients with the virus.
At one point in your statement, you make a particular point about general practice. It's your paragraph 105.
Yes.
You say general practice members reported that it became increasingly difficult to source clinicians willing to work in hot hubs without access to PPE, with the multi-source supply and confusing messaging leading to low confidence in the PPE supply system. What is your understanding of a hot hub?
So my understanding is that in the April of 2020, a series of primary care, general practice-based services were set up so that patients with COVID who weren't in hospital could access treatment if they needed to.
Your statement suggests that GPs and possibly other clinicians did sometimes have to work in those hot hubs without access to adequate PPE.
I think in the early weeks of the pandemic, there were absolutely reports to us, but also reports that were well articulated by our trade union colleagues and covered by the media, where people were improvising or in terms of PPE, or were having to reuse PPE when they really rather wouldn't, but also felt that the PPE they were being offered didn't necessarily meet the standard in terms of the difference between a mask with a respirator and a mask without a respirator that they believed they needed for the particular examination they were undertaking with patients.
In April of 2020, the NHS Confederation conducted a PPE survey in response to concerns raised. Could you talk us, it's your paragraph 106, talk us through some of the key findings of the survey?
So that was a survey that was particularly aimed at primary care representatives, so general practice in particular. I think the two things that stood out in that to us was that the majority, 83% of the people who responded, reported that they didn't have proper access to masks with filters, and that also reflected the fact that demand for those masks was higher than the guidance suggested, and that 73% reported a lack of adequate access to goggles and visors. The survey, you say, gave the opportunity for members to put in free text comment, effectively give you a bit more qualitative information. Can we look, this is just your statement. Could we bring up, please, INQ 000513763, page 36, where you've exhibited some of the comments you were receiving from frontline staff. Yes.
Paragraph 108A, one clinician says, had it not been for accessing PPE from schools and other voluntary organisations and from our own contacts with suppliers, we would have run out a long time ago. The national supply chain has been totally inadequate, the PPE emergency line has been unreliable, failed to deliver what was expected of it, and we still have no confidence in it. I do not believe that the initial guidance without visors or gowns was sufficient for seeing at-risk patients. These views are shared across our whole PCN. Pausing there, confidence, it's a theme of your statement, confidence of clinicians. Why is that so important?
And it's confidence, as you can see here, it's confidence in terms of supply, but also confidence in terms of the guidance, in terms of how that supply should be used. Again, this speaks to the anxiety of the people who were delivering care to members of our community with COVID or suspected they had COVID. It was based on the risk that they were very aware that they and their colleagues were taking and were being asked to take. And it was also, I think, increasingly reflected the particular risk factors that were becoming apparent for certain members of our community,
yes.
particularly our staff community, particularly our BME colleagues.
Paragraph B, please, just very briefly. Next clinician says, having tested people previously using a level 3 PPE and now testing using level 2 PPE since a guidance change, I feel uneasy. In the last sentence, you feel as if you need to do it and it has to be done, but can't help feeling concerned, more so about going home to your children and feeling as though you could be putting them at risk. I no longer give them a kiss. Quite a vivid piece of human impact. Was that sort of replicated across? Was that the feeling you were getting back?
Yes, absolutely. And of course, particularly for those in leadership positions in primary care, they were also practicing clinicians, so they were both providing a perspective in terms of the impact on their teams and their colleagues, but also they had first-hand experience of what the impact was on them as a practitioner. And yes, this is both illustrates the point I've been making about the changes in guidance and the confidence in guidance, people's belief that actually the guidance wasn't fit for purpose, and they were having to set higher standards for themselves and for their colleagues, and then yes, absolutely that impact.
For those who may not
people
have
and
been
their families.
following all the evidence, Mr. Mortimer, your correspondent meant by level 3 PPE and level 2 PPE meant, could you just explain for the audience?
Of course, my lady. The difference in different types of masks. So the level 3 in particular had respirators and added protection and was fitted in a particular way to make sure there was a proper seal on people's faces. Thank you,
Thank you, lady. Finally then, just sticking on the theme of guidance and how it relates back to procurement, can we look at paragraph D just over the page, please? It's this. There's a strong feeling amongst clinicians, said one of the respondents, that PHE guidance on PPE was not and is not evidence-based. It has altered several times, seemingly mainly influenced by supply rather than evidence. Was that a widespread feeling?
I think it's hard to say how widespread it was, but yes, absolutely there was a feeling that guidance and the reframing of guidance, which happened a number of times, was a function of availability. And there was a particular issue, as I think this person also refers to, around specifics in guidance, particularly around what was and what wasn't an aerosol generating procedure, and some difference of opinion. So PHE guidance was believed to have changed, and PHE guidance was also seen to be different to the guidance offered by the Resuscitation Council.
This clinician goes on to say, staff just want consistency in an evidence-based approach. They appreciate the truth and would have been and would still be much more accepting of a truthful approach. This is what you should have, this is what we actually have, which is considerably less, but do your best until we can upgrade you to what you should have. Our ingenuity would have helped us come up with solutions. This person then says, this has significantly negatively impacted the frontline workforce's confidence and belief in the centralised procurement and supply process, and it will be a long and difficult process to win that confidence back. Again, reflective of a wider feeling, do you think?
Yes, I think it was, and again, there was a belief that there was a lack of transparency, and there was a fragility to that. There was a fragility to that confidence over the months that followed.
Was there a communication issue as well, do you think?
Yes, I do believe there was. I mean, this colleague illustrates that in terms of the kind of honesty about what the supply issues were and the choices that were having to be made. And I think sometimes that was reinforced by, and this wasn't just an issue with PPE, this was an issue in a number of different areas, a sense in which things were announced at a nighttime briefing, ministerial national kind of lead briefing, without any kind of warning to colleagues in the service or any kind of preparation of colleagues in the service. And on occasion, that meant that people had to then the next morning implement something very different for the public or for their staff. So that confidence in that in the communication was very fragile at times.
Do you think that a lack of advance notice for clinicians, as you're alluding to there, had an impact upon their work, their credibility with the public?
Yes, at times I think it did. I mean, we saw it more clearly illustrated with in later months with the rapid changes to the vaccination programme, where the public absolutely took faithfully what had been announced by the government, but then the next day we're finding that primary care colleagues or hospital colleagues weren't ready to implement the change that had been announced somewhat unexpectedly the night before.
Turning briefly to a couple of final issues specific to procurement. In May of 2020, you wrote to Dame Emily Lawson and Jonathan Marren, witnesses both to this inquiry, with the results of the survey that you told us about before. INQ, please, 000391177. This is a letter from the NHS Confederation, dear Emily and Jonathan, so Dame Emily and Mr. Marren. Can you just tell us what was the trigger for this letter?
So this is a letter from my colleague Neil Dixon, who was the chief executive at the time. I think there were two triggers in particular. I mean, one was the long-standing and kind of growing concerns that we've been talking about so far this morning. The second was also the moves to further centralise PPE procurement, and in particular this sense that this direction that significant local suppliers would now be diverted to support the national effort rather than local effort.
Yes, and in fact it says in the third paragraph there, while we understand the aim to avoid NHS organisations competing in a challenging international market, because putting the alternative case, we've heard evidence that was a real concern of those charged with actually procuring this stuff. One I'm sure that's recognised.
Of course, absolutely recognise that.
You go on to say, we strongly urge you to reassure providers that attempts to achieve this will not compromise the supplies they currently receive. One of our members, a major acute provider, described what they see as further centralisation of PPE procurement as high risk. It is a view shared by others who don't have confidence in the government's ability to make decisions quickly, especially if sourcing from suppliers not listing on existing national frameworks. They may speak for themselves, but we can see procurement challenges very clear in that description, aren't they?
Yes.
Again, where now, looking back on matters, does the NHS Confederation think that the balance between allowing local supply versus a centralised national supply, where does that balance sit?
It's one of the most central questions in terms of how the NHS is organised and delivered in England. It's played a part in recent announcements and decisions by the government in terms of how it organises the NHS in England. There clearly were some decisions to allow the devolved nations some greater leeway to pursue, albeit coordinated, but slightly more autonomous paths. And I think it's always our reflection. I think the reflection that Neil sets out in his letter is that there's just something about finding a balance in the approach that's taken, and the fear about centralisation, about the slow decision making, about the lack of transparency, which we've previously talked about, was particularly felt in the couple of months prior to this letter being written, but is also part of the wider context for how the health service was operating immediately prior to the pandemic and arguably since then as well. So that tension between local and national is a constant, but there were particular confidence, as we've talked about in our previous exchanges, had been eroded in the 2 months since the pandemic had really escalated.
Thank you. One particular concern in a procurement context that you raise, your paragraph 115, is about push stock. You touched upon it briefly earlier. This was in the June of 2020. You say several members raised concern that the allocation of push stock of PPE was not representative of what trusts required.
Forgive me, could I see the specific paragraph?
Yeah, on the screen, yes.
If that would be okay, thank you.
Lawrence is probably ahead of me. INQ 000 513763.
Thank you.
Paragraph 115. Thank you so much, Lawrence. Here we go.
Yes.
In June 2020, several members raised concern that the allocation of push stock was not representative of what trusts required. One member said that despite sending our PPE modelling and working with McKinsey, the quantities that came through the push model is still not adequate in terms of quantity. This leads to trusts being forced to source their own materials. Again, possibly self-explanatory, but the real-world NHS frontline consequence of what looks like a sort of technical procurement issue.
Yes, I mean, a huge amount of work had been done with McKinsey. I think a number of our members had supported McKinsey in terms of trying to design this push system for trying to model demand and issue stock out to organisations. But as our colleague references there, that didn't meet what was actually happening in practice. And there was still occasions where people had to use the kind of local routes that we've described to supplement what was coming through that national system.
Quite a vivid description from the next member in your paragraph here. I don't know whether this is hyperbole or true, but the point is made. We seem to get delivered what is available rather than what we need. For example, I have several years' supply of visors now, but short of gowns, no ability to return them, so swapping in the local resilience forum, but delivery is not related to need. Do you think that was an issue? Clearly it's acute in the June of 2020. Was that an issue that improved? Was that feedback you got?
So any hyperbole, I think, would reflect the kind of concern
Absolutely.
that we've discussed, and that kind of heightened concern in particular about the risk that staff were bearing. Yes, absolutely. As we headed into the summer and particularly into the autumn, confidence increased, and the kind of resilience of supply, the adequacy of supply, improved. There were bumps along the road in that, of course, and some fairly significant ones. But yes, the confidence did increase. But even in June, as this colleague is illustrating, there were imperfections in the system, particularly in terms of how the push stock the push system works rather, and this requirement for people still to source stock or to swap stock through the local resilience forum, so the kind of coordinating mechanism there was in the various places around the country.
Just one other document to show you, please. This is August of 2020. Your then Chief Executive sent another letter to Dame Emily Lawson, seeking reassurance on PPE supply and stock. Lawrence, as ever, is ahead of me, but for the transcript, it's INQ 000 391178. You can see here another letter Dear Emily did, that's Dame Emily Lawson, isn't it? 12th of August. Here, recognising, second paragraph, significant progress has been made in recent months to move away from hand-to-mouth PPE supply chain, but we're concerned about a latest change and a concern there about needing to accompany that with mitigating measures. Again, a similar sort of seems to be part of the same debate around local versus national.
So, as you've highlighted, Neil had Mr. Dixon had a couple of exchanges with Emily, and in the June, Emily and Lord Dighton met a cross-section of members to talk about the issues and to kind of have first-hand feedback about the things that we've talked about largely, which are reflected elsewhere in the statement. I think what we saw in the August was changes to the delivery system, but a concern among members that the changes that they hadn't had sufficient assurance that the changes that were being made could cope with surges in COVID, and particularly if they were on a regional rather than a national basis. The plan, and there were plans developing in that summer to step back up elective activity, and then the impact that we knew came every winter, giving flu vaccinations, but giving flu vaccinations in the context of the pandemic, and urgent and emergency care demand, but obviously managing that kind of demand for urgent and emergency care, the stepping up of elective care in the context of a pandemic. So again, it spoke to this point about confidence. If you needed to, could you revert the system back to 24/7 deliveries? If you needed to, have you got sufficient stock to be able to respond to these kind of increases in demand that we expect or we fear may come through the autumn and into the winter?
Understood. Just looking briefly at the next paragraph. Furthermore, says Mr Dixon, we would welcome clarification on the impact, if any, the loss of 50 million face masks via the £252 million IANDA capital contract will have on the NHS. Yeah. Just pausing there, you may be aware that this module of the inquiry is looking at a range of different contracts. I'm not asking you to comment in my questions here on the correctness or otherwise of those particular figures.
Yeah.
But the letter goes on to say is the incident highlights why ensuring the PPE distribution network needs to remain robust and distribution immediately escalated if required. Confirmation that any impact from this incident on supply chains has been resolved and steps that have been taken to prevent future incidents of this scale will be most welcome. What I'm reading here is an example of a particular procurement issue arising, possibly in the media and being well publicised, and your organisation, through its chief executive, feeling the need to raise this at the highest level of NHS England. Is that right?
Yes, it is. And again, I looking at it now, it speaks to that question of confidence. And whilst the situation was improving, situations like this, and you're absolutely right, I don't know the detail. No. We wouldn't know the detail of the specific contracts or the organisation even that's named. But that being reported in the media impacts on the confidence of people in hospitals and mental health and community facilities in primary care. And there's something about reassuring them that the system can withstand and can cope with the loss of what feels like a significant element of product that people will be relying on, particularly in that context where there may have been some thankful receding of the pandemic over the summer of 2020, but people were anticipating further surges, as well as all the other things I talked about in terms of stepping back up some level of normal services. So yeah, it was absolutely about reassurance. It was absolutely about confidence and about wanting to understand that the system could cope with the loss of 50 million face masks, for example.
I want to ask you one very brief question about a topic about which we heard quite a lot of evidence yesterday, oxygen supply. Okay. It's your paragraph 138 and just puts a slightly different piece of the picture in. You say mental health wards in many places had experienced difficulty in accessing enough oxygen tanks to support COVID-19 patients. Why was that a particular problem, and was it one that you were receiving feedback was widespread?
So my understanding is that that's because patients who would normally, who needed non-mental health care, other physical health needs, who would normally transfer into an acute hospital, because of the pandemic, the threshold for that transfer had changed and they were being cared for in their mental health facility. And the use of oxygen just isn't as widespread in mental health clinical settings as it would be in an acute hospital. I'm not able to comment on how widespread an issue that was. If that was available, we could inform the inquiry afterwards, but I can't comment on that at this stage.
Final question. Any further reflections upon the evidence that you've given today? Anything else you'd like to add?
I think clearly the recommendations from My Lady will be really important in terms of the planning for future such events. But clearly organisations need to be taking action now, and we have seen some evidence of that, and I think that is important to emphasise. Clearly, other reviews have taken place. I've already referenced some of the things that supply chain are doing. And that includes, I think, importantly, not just the practicalities, the logistics and ordering systems and procurement and so on, but it's also about engagement. It's also about that building that relationship with organisations and particularly with clinical teams. I think that's the first piece. I think the second bit then is the need, as we've touched on, to understand how the people who were delivering services felt, the risk that they were carrying, the anxiety that they felt for themselves, for their colleagues, and as was illustrated for their families. And that was true for all parts of the workforce, but it was particularly true for people of colour, for ethnic minority colleagues, for colleagues who joined the NHS in such numbers from overseas as well. And that disconnection in terms of guidance sometimes, and steps were taken to resolve it, and I'm not minimising the things that particularly colleagues at NHS England did to try and respond to that during the course of the spring. But that's a really important lesson, that impact on people at the front line, and that need for transparency, but also responsiveness to that impact on colleagues.
Thank you very much, my lady. Those are my questions.
I don't think there are any Rule 10 questions. Thank you very much indeed
Thank you,
for your help, Mr Mortimer. I'm very grateful. And what you said there about understanding people on the front line, that seemed to echo, I don't know if you saw the evidence of Dr Kevin Fong about what it was like to be on the front line and how important it was to feed back to people at the centre
Yes.
exactly what was going on. So thank you very much indeed for your help.
Thank you, Mike.
My lady, the next witness, if I may, is Rosemary Gallagher.
Welcome back.
Thank you, my lady.
Bible in the right hand, please. Thank you. I swear by Almighty God
I swear by Almighty God
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth. Thank you very
Please
much.
sit down.
Thank you. Good morning, Ms Gallagher. Could you give the court your full name, please?
Rosemary Gallagher.
Gallagher, forgive me. Thank you. This is not your first time here and not your first witness statement, but for the benefit of this module, you've very helpfully provided a statement with the inquiry reference INQ 000553817. It is, in fact, a joint statement produced with your colleague Siman Shrestha.
That's correct.
37 pages long, and you signed it on the 13th of January of 2025.
That's correct.
And is that statement true to the best of your knowledge and belief?
It is.
Thank you very much. By way of very brief reintroduction for this module, you are the professional lead for infection prevention and control and the nursing sustainability lead at the Royal College of Nursing. Is that correct?
That's correct.
You were appointed to that role in July 2009.
Yes.
You say you currently sit on a number of external national committees aligned with the Royal College of Nursing, including the Royal College of Physicians Patient Safety Committee and the NHS England Emergency Planning Resilience and Response Clinical Reference Group, amongst others.
That's correct.
Your role is UK-wide, and the RCN and yourself respond to the needs of each country of the United Kingdom as they arise.
Yes, as a UK-wide organisation.
Thank you very much. In terms of the role of the Royal College of Nursing during the pandemic, its members work in a variety of hospital and community settings in the NHS and independent sector. Is that correct?
That is correct, yes.
And there are over 300,000 members employed within the NHS.
Yes.
The focus of these questions will be firstly the impact of any concerns that the RCN received arising in particular from the procurement of PPE, and secondly looking at any lessons which might be learned from yours and the RCN's perspective. Okay? Looking first at the section of your statement entitled Reports of Shortages of PPE, paragraph 11. The first section you talk about here is the RCN support service, RCN Direct,
Yes.
which consists, you say, of a call centre and online platform. Can you give us an overview of what was coming into that call centre? What kind of concerns, what kind of queries were coming into that call centre? This is your paragraph 11.
Yes, so at that time, the predominant theme of questions and queries and concerns coming from members related to the pandemic response, but specifically personal protective equipment, either access to or the type of PPE that they were being advised to use.
And the time we're talking about here is March of 2020, is it?
Yes, that's when the concerns really started to escalate.
The call centre, an online platform, received more than 3,500 queries just relating to PPE, did they?
Yes, that was an unprecedented number of inquiries that we received.
1,300 of those reported a lack of access and 700 related to general shortage or a lack of specific items, is that right?
Yes, that's correct.
You say that your members were telling you things like being unable to access a specific type of FFP3 respirator that they'd been fit tested for.
That's correct.
Is that quite a common concern?
It was at that time, under business as usual, not every member of the healthcare workforce would have been fit tested for respiratory protective equipment or an FFP3 mask. So there was huge demand for the workforce to be upskilled in this. Staff that had been used to wearing FFP3 masks suddenly found themselves without the normal type of respirator they had been fit tested for. So that necessitated a change and additional fit testing, and actually caused them significant concern because they were used to one particular mask that we were able to access. But then all of a sudden that market disappeared.
You say there was also a problem in finding alternative respiratory protective equipment or RPE when members couldn't tolerate wearing those specific brands. Is that right?
That's correct. So we had always and continue to work on the principle that if one mask doesn't fit correctly or for some reason is uncomfortable, that we would seek an alternative. So that was extremely difficult in those early stages.
You say there were also concerns about out-of-date PPE, some of which broke upon use or had physically degraded.
Yes, we had many concerns from members around material degrading, but particularly the nose bands. And actually members reported some really quite distressing incidents of respiratory irritation where they were inhaling the fibres from these degraded masks. So there was real concern, even though the process of relabelling out-of-date PPE was explained at the senior level, that actually what they were receiving was not fit for purpose and potentially causing them harm.
You say in your paragraph 12, a small number of members reported being asked to shave facial hair to be fit tested when this was inappropriate for religious reasons.
That's correct. So we did receive some support, reports of this. Under business as usual circumstances, those staff with beards that wanted to retain their beards would have been offered alternative respiratory protective equipment through different types of hood respirators, for example, but we simply didn't have the access to those in the numbers that we needed.
In response to some of these concerns, the Royal College of Nursing undertook what you describe as 2 extensive surveys of its members working across all health and social care sectors, first in April and then in May of 2020.
Correct, yeah.
And this was specifically about the use and availability of PPE to gain a better understanding of the depth and scale of the problems that were being reported through these
Yes.
call centre and online platform. Could you give us a flavour of the finding of the first statement, the first survey, published in April 2020?
So a significant number of members at that time reported being asked to reuse what had been designated as single-use PPE. So single-use means single-use. Staff have always had to work to that. So at this time, to be asked to reuse single-use PPE, which was there for their protection, was a significant cause of concern to them. A lot of staff reported a lack of eye protection, so we were very concerned around potential infection through the conjunctiva at the time, and therefore staff understood that this was required as part of the PPE ensemble, but wasn't able to be provided.
There was a second survey. That was the first survey in April,
Yes.
and it was extensive, wasn't it? It was more than 13,500
Yes, it was a
members
very good
responded.
response.
Yeah.
Yes.
Second survey in May, still a significant number of responses, more than 5,000. What were the key findings of that survey?
So the key findings of that survey were that some improvements had started to be noted in terms of the supply of PPE. There were still reports of staff being asked to reuse what had been designated as single-use PPE. And also, as with the first survey, staff reported concerns or a lack of confidence when raising issues with their managers that actually these would be resolved. So that was a persistent theme through both surveys.
You say that 34% of respondents felt pressure to care for individuals with possible or confirmed COVID-19 without adequate protection. And some 56% of respondents from ethnic minorities felt pressure to work without the correct PPE. Is that right?
That's correct.
You, I think, shared the results of these findings, if I may say, far and wide. You give the list in your statement: DHSC, the Prime Minister, the Scottish Cabinet Secretary for Health and Sport, members of the Welsh Senate, Audit Wales, the HSE and NHS England. Is that right?
That's correct.
You say that on the 17th of April, in response to the first survey findings, HSE acknowledged the survey results and noted that it was working closely with other government departments, including the DHSC, to facilitate efficient procurement and distribution and effective PPE. But you say, this is your paragraph 19, in their response, NHS England noted that there had never been a shortage of respirator masks or gowns and requested more data.
That's correct.
What were your members saying to you about this?
Well, the survey findings reported our members' lived experience of the provision and adequacy of PPE at that time. The survey questions didn't tell us why they responded in the way that they did, but that was their experience at that time.
At this point, did you have any concerns around the IPC guidance or modelling that related to some of these findings, or in particular the question of whether there was in fact a shortage of respirator masks or gowns?
Yes, many members had expressed concerns that the IPC guidance was actually driving the supply of PPE. So rather than the use of PPE being driven by what nurses on the front line felt that they needed based on their risk assessment, that actually the way the IPC guidance was structured at that time was leading them to wear, for example, surgical face masks as opposed to an FFP3 mask outside of an aerosol generating procedure, so a high-risk procedure. The modelling for the supply and demand of PPE, I understand, was based on the IPC guidance according to some statements in Module 3, and therefore that had a significant impact because the IPC guidance didn't take into account, for example, if you're wearing an FFP3 mask, the Health and Safety Executive advise a 1 hour continuous wear time, after which you're expected to take your mask off to support your skin health, for example, and then to apply a fresh mask. Staff also were so concerned around what they perceived as a lack of personal protective equipment, predominantly masks, and they knew they would have to remove all their PPE to go to the toilet or to have to take breaks, that they actually put off going to the toilet because they were so concerned that they would deplete the stocks, or that their colleagues coming into the next shift might not actually have enough personal protective equipment. So the whole considerations around how much PPE you use, not just on paper for a shift, but actually the real life on and off constantly during the day, they felt just wasn't taken into account.
Those sound like the sorts of experiences best understood at the front line.
Yes.
When to use a PPE, how long for, how it affects a toilet break or a break to have a glass of water or something to eat. I want to turn to how that, in your view and the RCN's view more generally, fed into the procurement process and how it might do so in the future.
Right.
In your witness statement at paragraph 23, as well as reports, as we've discussed specifically on the availability of PPE, your members were raising a number of issues about procurement, including, you may have touched upon this already, equipment not being fit for purpose. And you provide a quote here, which I may just read briefly from a member. So far, we have had 4 different types of mask from 2 different manufacturers. None have been clinically acceptable. They simply do not fit. I'm aware that contracts have already been signed to purchase. When I fed back to the Cabinet Office that they don't fit, I was told any mask was better than nothing. Another company on a call wanted to know how the NHS fit test masks, and when I questioned them on which trusts were already using their FFP3 masks or had evaluated, they said none, yet they had also been contracted to supply in the NHS. So a flavour of that kind of concern.
Yes.
Another one you've already told us about, I think, or perhaps this is different, poor packaging of PPE, which in turn impacted access to adequate PPE for nurses and other healthcare workers. Yeah?
That's correct.
And then this, what you describe as a lack of clinical engagement in procurement decisions. This is your witness statement, paragraph 23B. Again, to give a flavour, a member said this to you, or to your organisation: the clinical engagement is being done, in capitals, after the purchasing decisions have already been made. It's paying lip service to it and is too late once decisions have already been made based on tech specs, not, in capital letters, clinical specification and evaluations.
That's correct.
So that's the sort of the concern, and that's what was being expressed to and through your organisation.
That's correct. If I might just come in on that, the specification for a product, whether it's a mask, a ventilator, a wound dressing, is really just a description of the product and where applicable, what standards it has to meet. It's not the same as whether it can actually be used well in practice. So the procurement nurses that have specialist skills as clinicians understand how these products are used in practice. So whilst on paper it might say that it does it, what they were finding was that when it actually reached them on the front line, the products just simply weren't fit for purpose.
Well, I want to ask you then about procurement nurses. It's probably well understood that nurses deliver a significant percentage of physical and psychological care to patients.
That's correct.
But within the nursing profession, what is a specialist procurement nurse?
So a specialist procurement nurse it's a relatively new type of specialism. These are registered nurses that have worked in clinical environments, often from operating theatres to intensive care units, renal care, other areas, that have moved into support procurement teams in NHS trusts to make decisions about the right products for use in clinical practice. As nurses, we use the most consumables in the NHS, and we use them in many different ways. So these nurses are not only experts in how products are used, but they also are aware of how clinical practice is changing and adapting over time. And often the products don't, or there is a risk that products might not keep up with clinical practice. Also, clinical procurement teams may not actually have that clinical experience, so the word clinical can be a bit of a misnomer within the procurement world. So these are experienced clinical nurses that understand how products are used and can advise on benefits or contradictions to how they are used in clinical practice.
Something we heard a bit about yesterday in the evidence of the inquiry about medical technology was something described as a human factor approach, human factors approach. Is that something that...
So specialist procurement nurses would understand in depth the human factors aspects of how products are used and what makes it a good product or not. They would also be very knowledgeable on, for example, the implications for buying a poor quality product, because we may use more or we may not use them at all. So wastage is a real issue within the NHS and something that procurement nurses are very mindful of. And during the pandemic, to have these items of PPE delivered to their trust that were clearly not fit for purpose, to see the huge amount of waste that occurred as a result of that was actually really distressing to nurses, because they knew that if they had been involved at an earlier stage in assessing products that were coming to the UK, that they may have been able to avoid a lot of that waste actually, one, coming into the country, or two, actually reaching the front line.
Had specialist procurement nurses been working within the NHS procurement framework or system prior to the pandemic?
They had. So from 2012, the Royal College had been involved in work with the NHS National Customer Board, as it was at that time, and working through a clinical reference group, had been part of a piece of work, a proof of concept around testing the benefits of clinical evaluation led by nurses. So this was aimed at ensuring that the products that nurses had to use were fit for purpose, that they were of the correct quality and didn't harm either patients or staff, potentially. The work was undertaken through the clinical evaluation team and was so successful that it was adopted as a core criteria of how the NHS supply chain worked with the delivery of consumables across the board to the NHS.
In your statement, you suggest that this was something you were raising, or I should say the opposite, the lack of involvement during the pandemic was something you were raising as a concern.
Yes.
You give at paragraph 24 a particular example of a conference call with the Cabinet Office and NHS England, which you say took place as a result of member concerns following the publication of an interim PPE procurement structure. I just want to look briefly at that structure, please. INQ 000 417 641. This is a document you provided with your statement.
Yes.
If I may say, a slightly bewildering, I think we called it an organogram, headed the PPE interim team organisation as the 1st of July 2020. My suggestion, but please, your evidence, please say, it looks like an awful lot of procurement professionals and no clinicians, in particular, no nursing presence.
That was my take from this, as it was how the members interpreted it as well.
So you had concerns about that as soon as you saw this?
I did. I became aware of this towards the end of June and immediately raised it on behalf of specialist procurement nurses, because we knew the value that nurses could bring to the selection of products, given what a serious situation it was in. And it was actually really upsetting for those nurses and for us to find that the clinical voice was completely absent from this organisational organogram.
Thank you. Thank you, Lawrence. We'll take that down. By way of a follow-up to that conference call, you say later on you emailed NHS Improvement on the 16th of July, forwarding a large number of member concerns.
Yes.
You say you reminded NHS England there were a number of experienced RCN members who would be happy to support evaluation of PPE procurement, either via the DMC, which I think is the Decision-Making Committee, or as part of various groups looking into different aspects of current and future procurement of PPE. This, you say, was based on previous RCN involvement in procurement and clinical evaluation methodologies, which we've just been discussing, of consumables used by nurses to deliver patient care. To my knowledge, I don't believe this offer was ever taken up, and I'm unable to locate any response. Looking forward, one of the key lessons I think that you say should be learned is about the centrality of the involvement of the frontline perspective in the procurement process. Is that right?
Absolutely. We had learnt from the lessons in Ebola that those people that use PPE and need to receive education on its use, so donning and doffing, it's absolutely critical that they're involved in decisions about what is bought, what is clinically acceptable in practice. So that, in addition to our experience through the clinical evaluation team around the benefits of clinical evaluation, means that in a future incident, it's absolutely imperative that frontline healthcare workers are involved, and that we can also look at the needs of our colleagues that work with us. So they're very conscious of different face shapes, different sizes, religious and cultural needs, for example, and can bring that into the discussion.
Just one other brief issue in relation to the work of specialist procurement nurses. This exchange you were having with NHS England in the July of 2020, you say that you took the opportunity to, in your correspondence, to explain that you'd been contacted by one trust who'd raised concerns over the complexity of reporting issues with PPE, as some items needed to be reported via the MHRA and others via different routes, and how time-consuming you say this was if there were multiple issues. And then this phrase you use, adding unbearable pressures to specialist procurement nurses supporting NH trusts and wider systems at this time. So, not looking at procurement nurses from the point of view of before it's procured, but now you're there on the front line, there are issues to report. What does this tell us?
So, nurses are very aware of their NMC code, which requires them to report and address issues relating to safety or quality of care, and that also would extend to reporting issues relating to PPE in practice. Procurement nurses were under extreme pressure during the pandemic. They felt significant responsibility for ensuring that the correct and acceptable PPE was distributed to their colleagues in practice. So this was very, very personal to procurement nurses. They took the time, on top of everything else they were doing, to report issues, but they had to be reported through multiple routes, as you said, and it took an extraordinary amount of time to do that. And on top of that, they rarely heard anything back. So in terms of learning for the inquiry, what we and specialist procurement nurses would like to see in the future is a one-stop reporting system where the information is taken out. So you only have to report that particular issue through one particular portal. And this reporting and the pressure, of course, was felt across every NHS trust in England, and it would have happened in the 4 countries as well. So it represented a huge amount of time, but it was felt to be completely necessary.
Thank you. In terms of the, just finally then, you've provided a very reflective set of lessons learned and recommendations in your witness statement. I've only focused on a few of those today. Obviously, your full witness statement will be published and considered very carefully. Is there anything else, reflecting on the issues that we've touched upon in our discussion here, that you want to say as a lesson learned or a key reflection from what the experience of you and your members was during the pandemic?
Yes, thank you. So I'd like to reinforce the need for the clinical voice and specialist nurses to be part of all decision-making relating to the procurement of PPE, but also that process is transparent and formalised to avoid variation at a time of escalation. As with Module 3, we believe that we urgently need innovation in respiratory protective equipment to avoid the issues that we've seen time and time again through the pandemic around not just the supply of PPE, but the need to fit test on multiple occasions. But that PPE has to be developed so that it's not just acceptable for staff, but also acceptable for patients. And the other point, based on our findings from our survey, is that the needs and experience of our Black and minority ethnic staff in all care settings are explored, captured, and addressed so that we can learn from their experience to ensure that they are fully inclusive in the future as one team, but specifically in relation to the use of personal protective equipment.
Thank you very much indeed. My lady, those are my questions.
Thank you, Mr. Stote. Mr. Wilcox. Mr. Wilcox, over there.
Morning.
Good morning.
Mr Gallagher, I'm asking you questions on behalf of the Northern Ireland COVID bereaved Families for Justice. And what I'd like to do is, first of all, just show you an extract from the Northern Ireland Audit Office report, which is at INQ 0003488882. And if we could go to page 39, paragraph 7, please. This is an extract from, as I say, a Northern Ireland Audit Office report entitled The COVID-19 Pandemic, Supply and Procurement of PPE to Local Healthcare Providers. And you can see at paragraph 7 that it states that the RCN have raised issues over the guidance by which earlier paragraphs make clear it means the core UK infection and control guidance. In early 2020, with the Department of Health and the Public Health Agency, and also wrote to HSE, Health and Safety Executive Northern Ireland, in late 2020, stating that, quote, "We do not believe our members are being adequately protected with the current UK guidance that is being adopted within Northern Ireland," as well as highlighting members' views that employers were interpreting guidance based around PPE availability instead of what was required to protect staff. Now, you've told us about the concerns that your members had across Great Britain. So my question is obviously going to ask you to widen that to Northern Ireland as well. And the first question is it correct that the RCN membership in Northern Ireland were raising the concerns that their employers were interpreting guidance based around PPE availability at this time?
We did receive concerns from members across all 4 UK countries, including Northern Ireland. And certainly our country directors were very tuned in to their regional nurses and what was coming from the front line with the respective countries. So in answer to your question, yes, we did have concerns raised by members in Northern Ireland.
And do you have anything to add to what you told Mr Stote about what you meant by the phrase it was based around PPE availability rather than need?
Our members at the time were very concerned around the availability of PPE, and this coincided with a change in the IPC guidance and the downgrading of SARS-CoV-2 from a high consequence infectious disease. And there was real concern across the UK from nurses that this was predicated on availability of PPE rather than based on risk. So that was a common perception at that time.
Yes, thank you. And then finally, In terms of how the concerns were collected and recorded by the RTN within Northern Ireland, was that also through the RTN Direct service and the 2 surveys in April and May that you told us about, or was there something else as well?
So definitely with the surveys, members from Northern Ireland contributed. RCN Direct is a UK-wide portal, so members would have accessed through that one-stop shop. It's possible that members also contacted their regional leads within Northern Ireland separately, but I don't have access to that information at this time.
In any event, the concerns were there.
Yes, absolutely. Yeah.
Well, lady, thank you very much.
Thank you, Mr Wilcock. Ms Parsons, right over there.
Thank you, my lady. Good morning, Ms Gallagher. I represent the COVID-19 bereaved families for Justice Cymru. Just one topic, PPE and IPC guidance. So it is something that you have touched on already, both with counsel to the inquiry just a moment ago and counsel for the UK bereaved families. You've expressed concern, Ms Gallagher, in your statements to this inquiry that IPC guidance was not based on aerosol transmission of the virus, even though there was evidence that such a virus was transmitted by aerosol.
Yes.
In your opinion, as professional lead for IPC, why was aerosol transmission overlooked when it came to developing and updating IPC guidance?
The IPC guidance at the beginning of the pandemic was led by the 4 nations national IPC teams and members of Public Health England. I'm not able to speak as to why they didn't draw or adapt the guidance as the evidence was emerging. All I can say is that from a Royal College perspective, we viewed the risk of aerosol transmission as something that was very real and advocated and lobbied for our members based on that principle.
And to put it another way, or to ask you this, to follow on, Ms Gallagher, to what extent was the guidance due to a shortage of appropriate PPE, such as FFP3 masks?
We know that there was a shortage, but I'm not able to say exactly how short we were. We weren't privy to the information around the exact level of supplies and stocks of PPE at that time. What we heard was from our members telling us that there were insufficient supplies, or that the supplies were really, really tight in terms of a just-in-time delivery, with organisations and care homes sharing if they had surplus between them. So it was a very mixed and confusing picture at that time.
Thank you very much, Ms Gallagher. Thank you, my lady.
Thank you, Ms Parsons. Thank you very much indeed, Ms Gallagher. I suspect I might be calling upon you again.
I look forward to it.
I can't say that you're off the hook already, but thank you very much for your help.
Thank you, my lady.
Very well. Time for a break?
Just before we do, my lady, if I may,
Yep.
for the purposes of the transcript and those following online, I'm informed that the correct page reference for the document referred to by Mr Wilcock, INQ 000348882, is in fact page 69, not page 39.
Oh.
Thank you.
Thank you very much. I shall return at 25 to.
All rise.
Mr Sharma.
My lady, the next witness is Lord Dighton.
Repeat after me, please. I do solemnly,
sincerely and truly
declare and affirm that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth. Thank you.
I hope we haven't kept you hanging around.
No, you've been very prompt, actually. Thank you.
Lord Dighton, you've very helpfully provided to the inquiry a witness statement, 30 pages in length. The reference for it is INQ 000536422. I wonder if you'd be kind enough to confirm it's true to the best of your knowledge and belief.
Yes.
Lord Dighton, to begin, please, a little with your biography. You were the Chief Executive of the Olympic and Paralympic Games held in 2012.
Yes.
You were a minister at HM Treasury between 2013 and 2015.
Yes.
And in April of 2020, you became an advisor on PPE to the Secretary of State for the Department of Health and Social Care.
Yes, though initially, when I was appointed, it was with the specific objective of getting going on UK manufacture of PPE, and it subsequently was expanded to include the broader project.
Thank you. And we'll come on to those two periods during the course of your evidence. To deal very briefly with your appointment, it was in around April 2020 that you saw that the COVID crisis was deepening and that you wished to volunteer to help. Is that right?
Yes.
And so you approached officials in Number 10 to see if you could assist, and you were asked to support the Secretary of State, initially with the manufacture of PPE in the United Kingdom.
Yes.
The inquiry has heard a lot of evidence about the fact that global demand was soaring, the international market, as you describe in your witness statement, was breaking down, and that it was seen that domestic production was a possible medium-term to long-term solution to the current emergency. Is that right?
Yes.
Again, the inquiry has heard much about the work of the PPE cell and those working extremely long hours, a real fear that PPE would run out completely. And was that what you saw when you joined the PPE team in terms of the work ethic, the people that you were working with? Does that reflect your experience?
Yes. I mean, when I was appointed, what I decided to do was to join the team physically every day at the National Health Service office in the Elephant and Castle at Skipton House, because I just needed to absorb what was going on as quickly as possible. And there I worked really for the next 3 months in intense collaboration with Emily Lawson, Jonathan Marin, Philip Prosser from the Army, to try and get our arms around the problem. I think my initial observation was that they had, in very short order, put together a quite excellent crisis response to an extraordinarily difficult situation. It was very clear to me that anything that we'd had in place before had completely broken down. So, you know, I'm sure the inquiry will look at the resilience of what existed before. It was clearly not sufficient to cope with the scale of the crisis. It was also very clear that the sheer scale of demand, I mean, I think it's important to make this point, it wasn't just that we needed a bit more PPE, we needed thousands of % extra PPE. So the expansion in demand was more than exponential, it was astronomical, and it was all descending on the same constrained supply. Mostly, it appeared, from China, though it took us quite a long time to work out where it was coming from because our historical relationships had been confined to wholesalers. And of course, the whole world was trying to deal with the same problem of that enormous increase in demand and was competing ferociously for the very finite amounts of supply available at that time.
And so when you arrive, you see the team in the middle of crisis management. And in the words of your own witness statement, you describe good information as being scarce, not only on the quantity of PPE which was being purchased, but also on the timing of the delivery of the PPE to the United Kingdom. That was one of the problems that you encountered.
Yes, indeed, because of course, at this stage, all of our incoming supply was being imported within the chaotic supply and demand situation I just illustrated. We really had no experience of that market in these conditions. And so the team every morning would try and work out who was about to run out, where the potential supply to meet those shortages would come from, and try and define exactly where the supply was in that chain. So, for example, we might spend a morning working out how serious the traffic jam was getting a lorry to Shanghai airport cargo section. Those were the kinds of things that the team was focused on in a hand-to-mouth arrangement at the very beginning when I got involved.
I want to come on, please, to one of the first steps which you took, which was to bring in external experience and external advisors from the private sector. But before I do so, to emphasise what you have set out in your witness statement, that the team that you were working with were working under extremely stressful conditions, and you described them as having a clear sense of mission, and you described them as being the best of British. And so what I'm asking you about the bringing in of external advisors is not in any way to undermine the efforts of the team that you saw working.
No, not at all. I mean, the effort I just described was really working to bring in PPE from the international markets. My mission initially was to get some real traction with UK manufacturing, and the combined resources of the government at that point were wholly devoted to the international market. So there just was no spare capacity to be able to make the significant changes and jumpstart we needed to really make a difference for domestic manufacturing. So I decided the only way we would be able to make an impact was to bring in significant external resource with significant experience of what I would call delivery. So people who could engage with manufacturers and actually make it happen, as opposed to, you know, constantly reviewing lists and triaging lists.
You bring in a team from the private sector. Could you take us through some of the expertise that those in the team brought to the UK Make team and to the PPE cell as a whole?
Yes. When my appointment was announced, many people who knew me asked if they could help. I mean, this, I think, was the general sentiment in the country. There were just many people who wanted to help but were unable to find an appropriate channel. So my appointment enabled some of those to say, look, can we help you? As you mentioned, you know, I'd led the Olympic Games, and therefore I had many contacts who were accustomed to working together under pressure and delivering, and had, I would say, you know, demonstrated to me their capability, and we had a mutual trust about being able to get difficult things done.
Forgive me.
Yeah.
One of the aspects of your experience which you brought to UK Make was that you had experience, had you not, of working both in the public sector and also in the private sector. How do you think that assisted with bringing others in from the private sector to work on UK manufacturing?
What was essential to get things done was an ability to integrate sort of the private sector capacity to drive, innovate, and deliver with the public sector's understanding of how you get things done in government. So the key was not that one was any better than the other. The key was being able to get them to really work together. The team I brought in, you know, many of them had experience either in the public sector or working across in that way, so that they understood very clearly what they could do, which was to engage with the private sector, with the manufacturers to get them to the point of delivery. But then they needed to work with those in the public sector to get the support you needed there to go through the contracting and regulatory approval stages. So that integration was extremely important. And the ultimate way the teams worked was very much a combination of the private sector expertise that I'd brought in, dovetailing with the public sector expertise, which was partly in place and partly brought in to help me.
Just those 3 words you used, drive, innovate, deliver. Could you unpack those a little bit? What do you mean by those from the private sector being able to drive? What do you mean by them being able to innovate? And what do you mean by them being able to deliver? What was it that was unique about those who were brought in, which wasn't available within the public sector as you saw it?
I mean, I think we need to be careful about drawing too extreme a contrast. The principal challenge to the public sector resources, and indeed I think you've spoken to many of the procurement team from the Cabinet Office who were working on the buy side, they too were very experienced commercial operators, but they were fully occupied working with the overseas markets. So the principal issue at the time with the public sector was just a shortage of capacity, a degree of exhaustion, having been throwing themselves at a very, very difficult problem by that stage for over a month. And so bringing in the new capacity with a very, very clear focus. Our mission was to get PPE manufactured in the UK. So we removed the distractions of having to respond to the thousands of different questions, whether they were coming from the media or all the other, smaller offers that had been made. And I gave the team a very clear mandate, which was to find the manufacturers in each of the categories which could produce the volumes we required quickly, to the quality we needed, and at a competitive price. Very, very simple mission.
The second topic, if I may, following on from your answer, one of the innovations which you brought to the procurement and the manufacture of PPE in the United Kingdom was referred to by Mr. Jarvis as sprint and category teams. Could you help us, please, with why you thought that was the right response to the problems of UK manufacture, and what it was about sprint and category teams in relation to supply chains of PPE that made that the best approach?
I mean, firstly, with respect to categories, I think it's generally considered good practice to organise supply chains along a product line basis because...
Allow me to interrupt. Why is that?
Well, because you can see the whole supply chain. So giving one group of people the responsibility for understanding every step of the way and ultimately being able to balance supply and demand gave you a much better sense of control over the process. It also, given that we were essentially in startup mode, I needed the team to develop as quickly as possible sufficient expertise to be able to be effective, and category focus enabled them to get up to speed very quickly. I mean, and ultimately, I think it was the right way to go because once, by the middle of May, towards the end of May, that I was trying to get my arms with Emily and Jonathan around the whole effort, we essentially reversed the category teams that I had into the buy-sell. As I say, we moved from what I would have described as the crisis response to a more stabilized response as we realized we were beginning to get the right amount of supply in, both from manufacture and from overseas, and that balancing supply and demand was going to be an extremely important but difficult challenge.
So we have the balancing of supply and demand by the approach that was adopted on the one hand, and the other aspect of it was that the category teams could in effect become experts in respect of each of the strands of PPE with which they were charged with manufacturing and procuring. Is that right?
Yeah, and it also, you know, when you're having examined the landscape for that particular category, you know, you could quickly determine, are there manufacturers that already produce it? Are there manufacturers overseas who know how to produce it, who could be persuaded to open a production line in the UK? Were there manufacturers of allied product which you could help to adjust what they produced and how they produced it to create PPE? And then also, of course, if you're dealing with a number of companies, you're in a much better place to do price comparison, quality comparison, speed comparison. So for me, there were, you know, it was clearly the right way to proceed. And then the other aspect which you brought up, of course, were the sprints. We had no time. You know, as we've already discussed, we were really too late. So we couldn't spend weeks and weeks and weeks and weeks with a market survey. So essentially, I divided the categories into 2 batches. Batch one, half of them, batch one, I gave the first 4 or 5 days to the teams to survey the landscape, come up with a plan, triage it down to the 4 or 5 opportunities that we should pursue. Week 2, the other half of the categories. And we then had a good enough plan to begin to get into detailed discussion with those manufacturers and work out how to bring them through the contract and technical approvals requirements.
Thank you. And we'll come on to that in just a moment. Your interface with those who were involved with the manufacture of PPE, you took a different approach, am I right, than the call to arms, in that you identified and approached manufacturers. You selected them. We heard from Mr. Jarvis on the basis of their ability to scale up manufacturing at speed and at the right price. From the point of view of the manufacturers that you were interacting with, what was it that they needed in terms of support and assistance from the UK government and your team?
Yeah, I mean, I think the first thing they needed was our focus and engagement, so they knew we were serious about getting this effort moving at speed and with scale. I think they then, you know, basically needed the comfort that they were going to get a contract, because that would enable them to bring, in most cases, bring their furloughed workforce back into the factory, and in some cases to invest in the machinery or move the machinery around that they needed to make to produce the equipment. With respect to the, you know, so we worked extremely hard with the help of, I mean, you've heard Mr. Jarvis's evidence, with the help of government colleagues to get as clear a definition of as possible of the product guidelines, because I mean, the manufacturers were brilliant in their response. I mean, most of the innovation, the urgency, the delivery came from them once we put them in a position to be able to respond. So I don't know how clearly that's come out in the evidence of the inquiry so far, but I really do want to salute the response we got from British industry. Once we made it possible for them to contribute, they were outstanding in their response.
Could I just interrupt you there just for a moment? So one of the areas in which manufacturers needed assistance was in terms of financial assistance. Is that right? Support from the government?
Well, the principal way they needed financial assistance was the assurance of the contract. So getting paid was actually the principal thing that made them happy to get up and get going. And then there were other bits of help that we gave them, but they were extremely creative about solving the problems themselves, because they were motivated both to put volume through their own operations, which were suffering at the time because we were in the midst of COVID, bring their workforce back, as well as a very strong motivation, which I sensed everywhere I got involved in this in this project, to help. So they were extremely motivated, and we worked with the technical, the regulators, essentially to make sure we had the clearest possible product guidelines, because once there was clear definition, these manufacturers were in the main wholly capable of producing to a well-defined product definition, right down to creating templates for them that they simply needed to copy. You then need to take them through a testing process, which had its challenges. I mean, if we step back and just look at the whole environment for producing and getting to the workforce PPE.
Lord Doe, forgive me if I just want to just bring you back to this subject, and then we'll come on to the regulatory approvals and the testing houses. Just to come back to what the manufacturers needed, if not financial support, we've heard from Mr. Jarvis that some of the assistance they required was in order to retool and provide blueprints and specifications for the sorts of equipment that they needed to produce. How did your team assist them in that process?
The team I brought in was working with the manufacturers. They would essentially handhold each of their client manufacturers through the process with the different parts of the regulators and the government to meet each of, I think, what elsewhere has been defined as the 8 steps of due diligence. But of course, when you're dealing with a domestic UK manufacturer, many of those are extremely straightforward. You know who you're dealing with, you know what their financial condition is. So most of the approval issues become those around regulation and safety. And that's where a lot of the work was focused. And we would help bring together those people in government who understood what was required and essentially provide the interpretation between what the company needed to know, what the regulators needed to see, and ensure that that was satisfactorily resolved at pace.
You referred to the 8-stage process. I wonder if we could go to some of the written evidence in your witness statement. It's at INQ 000536422. This is page 7 of your statement of paragraph 19.
Yeah.
I just want to take you through a few paragraphs of your statement about the 8-stage process and how you assisted manufacturers through it. You describe here that our team had managed to streamline the entire end-to-end process of design through to manufacture, including procurement processes and governance approvals, to ensure that new domestic PPE supplies were rapidly approved in a robust and legally compliant way. We'll come back onto the issues with safety regulations in a moment. Key to this streamlining was the appointment of category leads, which you've covered, and then rather than changing the regulatory procedures, which were consistent and thorough, companies were better guided through each step by having a representative and point of contact throughout. And this is the area I'd like you to focus on, please. Therefore, avoiding the cumbersome handover process between each stage of the approvals process. Could you help us, please, with, first of all, what is it that you mean by streamlining the entire end-to-end process? And secondly, what is it that you mean by the cumbersome end-to-end process?
Yeah, I think the key thing was that we had a relatively small and focused group of significant manufacturers, each handheld by a member of the team. So nobody was left, nobody from the outside was left really having to negotiate each part of our own process. They were taken through that process. So the streamlining really was the way in which it was handled to take them through there. We'll talk about some of the regulatory things later, but there was some streamlining there, moving sequential processes onto parallel processes. I think I've already referred to the fact that by this stage, when we had a supplier going through the contractual stage, the category team would also have included somebody from the government side who's very familiar with the contractual process. So again, integration was absolutely key.
Could I just interrupt you there? You refer to moving from a sequential process to a parallel process. What do you mean by that?
Well, the nature particularly of product approvals was, you do one thing, then you go to the next thing. And in certain cases, when we looked at it, there was no reason for one to follow on from the other. You could do two at the same time. In peacetime, in normal time, of course, the whole point about safety is that it's a slow and highly deliberate process. We still needed deliberate, but we didn't need slow, so we could parallel up the normal processes that they would go through, and then you simply have to deal with capacity issues. And as you mentioned, testing houses was one of the constraints we had. So there was some attempt, again, with the help of our friends in Bays, and you heard from the excellent Mr. Jarvis, to increase capacity domestically and then to add shift work on that capacity so you could work 3 shifts a day rather than the customary 1. So those were the kinds of things that one does in a crisis to expand capacity and to speed things up.
So what you wanted from your point of view was a move from the step-by-step process to a process in which multiple parts of that process could be completed at the same time. And is that essentially what you and your team were leading the manufacturers through?
Yes, and it's, as I think you've already suggested, much easier to accomplish that with domestic manufacturers because they're there, you can deal with them, it's face-to-face, you can see what they're producing, the prototypes. Whereas my colleagues in the buy-sell trying to work out who was a manufacturer in China or somewhere else, where the wholesaler was, whether the wholesaler was ordering from another wholesaler, with lots of companies that seem to have been recently set up with limited histories. Each one of those steps could be very, very difficult for them to confirm, which is why in that case it was much more likely you'd get lost in a process because many of the steps weren't being properly fulfilled and people were being sensibly cautious about charging ahead.
Could you help us with this, please? You've described the manufacturers that you're dealing with as having been experienced previously in manufacturing, perhaps not necessarily in PPE or even related products. Why was it that they were finding such difficulty in navigating this process that DHSC had established?
They weren't. The manufacturers in the main had not got to that point. I think once we'd established our focused, fully staffed, ready to go make effort, the hand-holding through the process worked well. So it wasn't that they were stuck. I think when I'm describing some of the challenges in the process, I think that's what our colleagues in the buy-sell looking at the international market were experiencing for all the reasons I just laid out.
You described further in your statement, and we don't need to bring it up, not only as cumbersome, but that you needed to move to a more efficient approach to oversight of supply and demand. In fact, maybe we should bring this paragraph up. It's INQ 000 536 422. It's page 27 of your statement and paragraph 84. Thank you. You said, as you set out in more detail above, the restructuring of the teams you've described resulted in a more efficient oversight of supply and demand for each category of PPE. Is that what you were referring to when you were describing having organised the teams into categories and therefore being able to better predict what was being supplied and what was being demanded?
Well, certainly one component of establishing better control over the crisis situation, in my view, was having a category-structured organisation, but that was really only one component. The real once I felt that we had established an excellent make effort where I had very strong leaders managing sort of the day-to-day process of contracting and delivery, I moved over to look at some of the problems in the broader effort, working very closely with Emily Lawson and Jonathan in particular. And the real issue was establishing the facts. I mean, ultimately, one of the reasons I was there was to assure the Prime Minister, who was extremely focused on this topic, that we had enough PPE. Very simple test, because then that had implications for lockdown, and it meant that resources could move on to other priorities like the vaccine, like test and trace. So the Prime Minister was insistent that I could demonstrate to him that we had enough. I was there because we had a relationship, given how I'd worked on the Olympics when the Prime Minister was the mayor. And in order to do that, we needed better facts. We needed to understand how much PPE we already had. We needed to understand how much was being used, which required an understanding of how many people were going to get COVID, what kind of interactions the medical staff would have with the patients. I then also needed to understand every step in the supply chain to understand where the orders that had been placed were, and when they were going to show up, and what sort of state they were going to be in when they got there. So we had to create a model out of that to determine where we would have shortages and where we would have surplus, to create what in the supply chain terminology would be called a demand signal. So getting better and better information to make that demand signal more and more precise. And so sort of the middle to the end of May, I worked with the team to try and get a grip of that. And I think by the 21st of May, third week of May, I was able, with the team, to say to the Prime Minister, we have it covered for both the short and the medium term, because, of course, there was a lot of focus on being prepared for the anticipated second wave in the coming winter.
Lord Dighton, that is, if I may describe it, as the data problem that the inquiry has heard some evidence about, the effect of there being a model for the amount of PPE which was anticipated would be required during the pandemic, and the effect of delays in delivery, for example, of equipment that was being bought from overseas, the breakdown of logistics and supply chains into the United Kingdom. Is that right?
Yes. So every part of that data set to create an accurate model had significant elements of uncertainty. And you've described it well on the supply chain side, because it's very difficult to know, given the chaotic state of things, exactly when things would turn up and whether they would be safe to release to the front line. And on the demand side, it was, good demand modelling or accurate demand modelling is at its best when it can be supported by the most recent and equivalent experience. The problem here was nobody had any experience of COVID, how it would spread. Nobody had any experience of the utilization of PPE during COVID, and therefore trying to estimate into the future how much of this you needed was heavily assumption-based and therefore subject to considerable error.
Thank you. Lord Dighton, we're going to come back onto that in a moment. If I can bring you back, please, to the issue of regulation and technical specifications and the persistent, if I may describe it in those terms, problems of complexity of regulation and getting equipment from manufacturers to the front line. Now, of course, no one, not least anyone in this inquiry, suggests that even in an emergency, that regulation about safety is something which ought to be compromised with. But from your perspective, and dealing with the manufacturers at the time, was there complexity in regulation, difficulty in dealing with the regulators, and trying to navigate that regulatory landscape?
Yes, I mean, I think with any safety system, the issue is never keeping the bad stuff out. The issue is always getting the good stuff through quickly, right? That's always the challenge. And I'm sure every witness has told you that actually the processes to ensure that nothing unsafe got to the front line were never compromised. And that actually gave me a certain amount of comfort as I pushed for speed that, so for me it's actually comforting that there was a degree of pushback to make sure that the product was safe. So this is not an unhealthy tension in many respects.
And so just to be clear, when you're talking in your witness statement and your evidence of the inquiry today about streamlining and speeding up processes, you're not describing, are you, compromising on the safety standards that either UK Make or the PPE cell in general was approaching the problem with?
No, the regulators, we would take to the regulators a case of something we wanted to do slightly differently or slightly more quickly, and essentially put to them the question, what does it take for you to be clear that this will be safe? And they were prepared to be flexible in saying, well, you're right, we don't really need to do that thing that we would have traditionally done. If you do this, that'll be fine. So it was a case-by-case, pragmatic, working together sort of crisis approach to helping everything through, making sure that the safety concerns were still appropriately considered.
Could we have a look, please, at perhaps some practical examples as to how this played out? INQ 000477711. These are the minutes of what was called the Regulatory Coordination Cell, which brought together entities such as the Health and Safety Executive, the MHRA, and the OPSS, whose witness evidence we've heard from Mr. Graham Russell. This was on the 5th of May of 2020, not a meeting at which you were present at, but at which reference to you is made. Under public face coverings, please. It says under here that the HSE is holding the position that they're talking about public face coverings are not PPE. The MHRA are confirming these do not meet the definition of a medical device. And then there being other issues. And then if we can come down to the decision-making committee, DMC, beneath. There's a reference there to an apparent disconnect between you, Lord Dighton, and HSE on pre-approved designs and specifications. And that, is this an example of the sort of pragmatic approach which you're describing? What was happening here from the best of your memory?
My memory doesn't connect to this specifically. It sounds very yes, Minister, doesn't it? I was apparently disconnected. I think I would have been driving hard to push things through, and this was all part of the negotiation to get us moving at speed. And 5th of May was pretty early in my tenure there, so this would have been at the beginning of trying to find the right equilibrium between push and accept, the tension I described earlier.
You describe in your witness statement, we don't need to bring it up, but it's at paragraph 83, that you believe this largely related to the need of clarification of technical specifications and ensuring clear communication to the manufacturers, and that you saw the role of your team was to deal with any uncertainty that the manufacturers would have in relation to the guidance and the specifications of PPE.
Yeah.
So is it right that rather than seeking to solve the underlying problem of the complexity of the regulators and the regulation, that you and your team saw yourselves as problem solvers to make sure just that the PPE and those manufacturing it could navigate their way through the system?
Yes, let me give you an example. So, aprons. There were no manufacturers of aprons in the UK, but aprons are made of plastic, and there are people who make plastic things. So we found out who the best manufacturers of plastic bags were, and the essential difference between a plastic bag and an apron is that you have to cut 3 more holes in the bag to put your arms and head through. Therefore, what we had to do with the apron manufacturers were to help them install cutting machines for the final end of the process, and then help them determine how to package the aprons, because the health service likes to pull them off a reel rather than take them out of a box. The other thing that matters is the weight. People don't like their aprons too light because they fly up. They don't like them too heavy because they're constraining. So in the case of aprons, getting the weight and the distribution mechanism right were the key things the manufacturer had to understand. In the case of masks, I think the initial contract we worked on was with Honeywell. Honeywell clearly knew how to make masks. They were making them all around the world. And the proposition with them is that they opened a production line for masks at their factory in Motherwell. And so they really just needed to understand, well, what do the British standards require? And so in each case, you can see there were particular things that specifically mattered for getting that order to the front line.
The inquiry received evidence from Mr. Russell from the OPSS, and he was asked as to whether the regulatory landscape, which the manufacturers that you were working with, was fragmented and complex. And his evidence was that from the regulator's point of view, they had to take into account the fact that the equipment that was being manufactured was going to be used by different people in different places and for different purposes, and that where regulation was there to mitigate any potential risk, that you would always have to find a dividing line between different regulators and different regulations. Was that a problem for the manufacturers who, tell me if I'm wrong, had in their mind that what they needed to manufacture was PPE to be used in a health emergency and to manufacture it as quickly as possible? The manufacturers were results orientated. They were looking at this from the point of view of how do we make the PPE for the emergency at hand?
Yeah, I mean, I think you're right. In a situation where you're trying to move at speed, having a fragmented environment to operate against is not helpful. I think what the regulators usefully did was to come together and to act in a coordinated way. There was some discussion as to whether lead regulator status should be given to one so we could just get a yes or no from one. But I think, as Mr. Russell's implying there, that wasn't something that they felt would work given the different responsibilities they had. But I think given the short notice we had, given the nature of the crisis, because we were giving them the right focused questions, I wasn't unhappy with their speed and flexibility of response.
Would it have made your job and the job of the manufacturers easier for there to have been a lead regulator, or for there to have been a single, to use your word, streamlined set of regulations, still with an eye to safety at all times, so that in the case of an emergency, if a manufacturer needed specifications, blueprints and so on, they had a single place to look and a single regulator through which to get that which they were manufacturing through the system.
Yeah, I mean, I think by definition that has to be quicker. And what you're really doing there, if these regulators have different responsibilities, is you're asking the lead regulator to take responsibility for getting agreement from the other regulators. And given that they speak the same language and broadly have the same objective, you would expect them to do that better than for non-experts to have to negotiate with each of them bilaterally.
Thank you, Lord Dayton. Just moving on to another topic, please. To explore with you what you consider were the root causes of the UK's over-purchasing of PPE. You've touched on some of the reasons for it a little earlier. The data problem, the inability to predict that which was in demand and what was going to be supplied. Could you provide your reflections on other reasons that you think that the UK had over-purchased PPE?
Well, of course, if you look at the documents that the team produced at the time, we weren't consciously overbuying. We were buying to the modelled demand. So the answer to the question sits in an analysis of why those estimates or modelling proved incorrect. And I think I've referred to some of those already. It has a lot to do with model demand being in excess of actual demand. Partly that will be because we were conservative in the model demand. Partly it would be because people were rationing their actual utilisation, and so the difference diverged. And just think about it. If you use a mask twice rather than once, you've halved the number of masks you need. It makes an enormous difference. I think by the beginning of June, this was one of the advantages of the category approach. I remember vividly my category lead on eye protection saying, ignore the model. I can just see what's going to start piling up in the warehouse. Let's stop ordering, which we did. But the model would have suggested you kept ordering. So,
and I think that's what you refer to in your written evidence as common sense adjustments to the PPE that was being purchased and manufactured.
Once you had enough visibility to apply common sense, yes.
One of the critical problems that Mr. Marin explained to the inquiry about predicting the supply of PPE during the pandemic were the problems caused by the lead times in respect of equipment that was arriving from overseas. And then secondly, as to whether what was arriving from overseas markets would be of suitable quality. There was another unknown factor in that. It was difficult, if not impossible, to conduct inspections at remote locations. Are there any advantages from the UK make and the UK manufacturer in respect of that problem?
Yeah, I mean, in every respect, if you have access to competitive, high-quality domestic manufacturing, it takes all of the challenges around the uncertainty of deliveries from overseas in a difficult market environment away from you, right? You have immediate control and visibility on every aspect. I mean, we could see the pallets piling up at the end of the production line. We had control over the lorry to take it to the warehouse and then to distribute it. So it both would significantly shorten and give you total control and visibility over the supply line. Clearly, the international buying we were doing didn't really have any of that.
And what about with respect to coordination, domestic manufacturing, how can coordination be improved by the fact that items are being manufactured in this country as opposed to being purchased from overseas? Forgive me, let me explain that. What I mean by coordination, I mean coordination with other aspects of government policy. So for example, the rollout of the vaccine and the effect that would have on the demand for PPE, on lockdowns, on hospitalisations. How is coordination made better by reliance on domestic manufacturing?
Well, it simply gives you control. It's as simple as that. Your destiny is much more in your own hands. The uncertainty is diminished by a significant number of factors, as we've discussed.
And finally, if I may, turn to the issue of timing. The UK Make programme really only started getting going in April, with delivery of the first items of PPE, according to Mr. Maron, just 25 days after it was established. Now, of course, this is with the benefit of hindsight, but with foresight and planning about scaling up the UK domestic manufacture of PPE, what effect would that have had on PPE procurement during the pandemic?
Well, with foresight and planning, you probably would have pressed that button in February. I think, and I've agonised over this, I think even in the crisis we were in, the effort I was able to start at the end of April, I see no reason why that couldn't have started at the end of March had we got ourselves organised and focused that way.
And as part of that foresight and planning, you provide in your written witness statement a number of reflections, including the identification early, perhaps pre the next pandemic, of strategic manufacturers in the UK. Is that right?
Yes.
And the other observation that you make, in addition to diversification of supply from other jurisdictions, is to keep an eye on access to raw materials. Could you explain why that's important to domestic manufacture?
Yeah, indeed, because clearly you don't solve the problems we were discussing by simply having the manufacturing capacity if you're exposed to the international supply of some of the raw materials. So you have to trace your domestic supply chain back through to to every single component part to make sure that you have access to that if it's going to be effective.
Thank you, Lord Dighton. Just before I close, I wonder, are there any other further reflections that you have in relation to your experience of the PPE cell and the UK manufacture of PPE?
I mean, I would just reinforce, I think, a couple of the points that I've already made. I mean, firstly, the problem was our lack of preparation. Those who came in to deal with the crisis were heroes, and nobody could have done any better. That was when I was brought in by the Secretary of State and the Prime Minister. One of the things they really wanted me to do was to check whether the people working on it were okay, because I arrived in a situation where the country was hurting, where the government was seen not to have a grip, and we had all these offers of PPE, yet the front line was running out. And so when I went down to Skipton House on that first morning, I was mostly trying to work out whether the team there was up to it. And they were 100% up to it. So I think it is important for the inquiry to understand that I think the work done in the heat of battle was outstanding. And I think the other thing I would just call out, and I have I think already referred to this, I mean, the response of the manufacturers to get this done fast and delivering stuff that was competitive, that passed the safety test, that was used, was outstanding. And I think we should acknowledge that when we reflect on this crisis.
Thank you very much, Lord Dighton. My lady, I don't have any further questions.
I think there are some questions. I think Ms Morris is going first. She sits just there.
Thank you, my lady. Lord Dighton, I ask questions on behalf of the COVID bereaved Families for Justice UK. I'm first going to highlight 4 pieces of evidence to you, if I may, and then ask you 2 questions about them. The first piece of evidence is an email, that's INQ 494747 on the 30th of April 2020. This is an email between yourself and Lord Feldman, and it's at the email 1154, please, just towards the top there. Thank you. It says there, Dear Paul, that's yourself, a connection with a UK-based visor manufacturer struggling for a change to get any traction with the NHS, introduced by the wonderful Stuart Marks, that's Lord Marks of Hale, is that correct? The Northern Treasurer of the party and tech entrepreneur, so a really trusted source, seems to sit in your remit. Warmest best wishes, that's Andrew, and that's Lord Feldman. Next document, please, INQ 494748. This is an email now dated the 27th of May 2020. And it's the email at 1855 at the top. Thank you. This is Lord Marks emailing you directly this time. Hi, Paul. Hope you are well. Wondering if you can be any help with this. As mentioned in the early emails, the company are desperately trying to hold on to staff to avoid furlough, but have been waiting for confirmation on whether the company has been selected. The CEO at Vogue, this is the company that Jonathan Salem is representing, has been speaking to X, who's been helpful but is unable to prioritise the case and says he's waiting for a closing team member to pick this up. They believe that they have a competitively priced UK manufactured product and have been approved to supply. Is there anything you can do? The CEO really needs to make some business decisions. Best regards, Stuart. The CEO there is Mr. Jonathan Salem, and the inquiry has a statement from Lord Marks who confirms that Mr. Salem was a friend of a friend, and the company that Mr. Salem had founded represented the Paper Drinking Straw Company. It's since been reported by the Good Law Project that the PPE supplied by the Paper Drinking Straw Company was entirely unfit for use, and that every single one of the surgical masks that they supplied was unfit for use. So my questions are this. Why does being introduced by a Conservative Party treasurer, that's Lord Marks, make a potential supplier, quote, a really trusted source in Lord Feldman's view?
Well, ask Lord Feldman.
Did you agree it was a really trusted source?
Indifferent.
Following these emails, did you take any steps yourself to assist this company to secure a contract for PPE manufacture?
Well, I think if I look at those 2 emails, the first email was the end of April.
Yes.
The next one was the end of May. You can see how much urgency I attached to that introduction. So, no.
Did they, to your knowledge, have their hands held in the way that you described in your evidence this morning?
No.
Next set of questions, please. And this is another email chain, INQ 494749, 17th of May. This is again an email from Lord Marks. This time forwarding on a message from Haraldar Agutson. Lord Marks says at the top there, I'd be grateful, dear Paul, I'd be grateful if you could take a look at this. Haraldar is a generous and loyal supporter of the party. And you respond just a bit further down, saying, a bit further up, saying, will do. So in respect to this referral, what did you do in response to this email? Did you do anything to assist this company to secure a contract?
Well, if you read this email, he is essentially complaining that we have favoured a series of other mask manufacturers. Alpha Solway, and he actually has a point, Alpha Solway was a serious mask manufacturer, so we should have considered him seriously, but unfortunately he didn't make the initial triage.
So now he's coming to you, and the information you've got is he's a generous and loyal supporter of the
Irrelevant.
party.
That is irrelevant to me.
Okay, but do you accept that these sorts of introductions and direct requests for personal assistance to you amounts to a request for preferential treatment by political connection?
I think if you'd have been... I was bombarded by different parties trying to help, is how they would have described their situation. Personally, I find it odd and slightly off-putting when the introduction takes that form. I've been in a number of jobs where I have power and therefore people seek to influence me. Frankly, when they do that, it's unhelpful rather than helpful.
Did you consider whether these raised conflicts of interest or due diligence issues?
Yeah, I mean, I think had I pursued it on any favoured basis, I absolutely recognise that, but I didn't. I think, as you've seen from the way I triaged all the make contracts, we had one set of criteria which were about the ability of the company to deliver the right product fast, at scale, at a good price.
So from your answer a moment ago, do you consider that these approaches to be at all improper at the time? You said you were bombarded.
I think it was the nature of where we were that the government and the country had asked for help. We clearly didn't have enough PPE. People who thought they could help with that were trying by every means they could to advance that. I agree you have to be thoughtful about how you then prioritise and allocate efforts. I don't think I could have been clearer about how I did that.
As part of that thoughtfulness, did you inform the civil service procurement officials about the source and nature of these introductions in advance of the offers proceeding through to the opportunities stage?
I wasn't part of that process.
Thank you. Thank you, my lady.
Thank you, Ms Morris. Next, I think it's Mr Stanton, who's right over there.
Good afternoon, Lord Dighton. I ask questions on behalf of the British Medical Association. At paragraph 21 of your statement, you refer to your efforts to get a clear picture of PPE supply and demand. And you make reference to a piece of work carried out by McKinsey and Company in conjunction with DHSC. And I'd just like to take you to a few points in that particular demand report. It's at INQ 000-339-131, page 3, in the first instance, please. And Lord Dighton, at the top line of the document before you, you can see it concerns the issue of FFP3 respirators, and the concerns identified in the second column are that demand will burn down existing stock, and there's also a concern identified that the forecast supply was inconsequential versus demand. And then in the final column, actions, there are some proposed actions. The first bullet point, increase acquisition. The last, third bullet point, approve FFP2 masks as a substitute. But it's the second bullet point that I'd like to bring to your particular attention, please. Reduce demand with policy. And you'll find a second reference to this proposal at page 5 of the document, which hopefully you'll have before you. Yes. The shaded box on the left, Lord Dighton, indicates a proposal to ensure that there is sufficient PPE in the right place at the right time for all staff. And then bottom line, again, we have proposals, one of which is optimise usage and a proposed action to revise the guidance, e.g. PHE, Public Health England. And then the final reference, please, Lord Dighton, is page 10. And here, hopefully you should see the guidance or policy on use of PPE. The first box deals with high-risk procedures and settings and indicates the use of FFP3 respirators for those purposes. And then in the second box, other settings, we see here even healthcare workers who are engaged in close personal care of patients with COVID-19 don't get an FFP3 respirator. They have a fluid repellent face mask. And my question, Lord Dighton, given your role in leading the UK's domestic manufacturing of PPE, is were you aware of the recommended action to manage and reduce demand for FFP3 masks through policy rather than by prioritising procurement and manufacturing?
This document, I think, was the 29th of March. I joined a month later. The situation was just completely different by that point. So these were clearly sort of much earlier efforts to kind of deal with the chaos that, I mean, this was the high point of panic and uncertainty. So that's the environment. So by the time, 4 weeks was a lifetime during that period. So this document is, just completely out of date for the situation I was confronting.
So at the time you took up your post, these issues were not issues that were brought to your attention?
We were not trying to constrain demand. We were just trying to get every single piece of PPE we could, because we understood the anxiety, the fear on the front line, absolutely.
Thank you, Lord Dighton.
Thank you.
My lady, thank you.
Thank you, Mr Staunton. It's Mr Dale.
Thank you, my lady. Lord Dighton, I ask questions on behalf of FEMO, the Federation of Ethnic Minority Healthcare Organizations, and I have one short topic about the structures that existed for procurement decisions. And my question is this: what frameworks or oversight mechanisms were in place within PPE MAKE to ensure procurement decisions met the needs of all healthcare workers, but specifically those from ethnic minority backgrounds?
The supply side was really responding to the guidelines and requirements that came from the National Health Service. So the procurement was certainly in the early stages just trying to get more equipment. What became apparent, and it probably became apparent to me mid to the end of May, was that there were some size issues, some shortage of very small and very large sizes, and then that became particularly focused on FFP3 masks, which are the tight-fitting heavy filtration masks, which are uncomfortable to wear for a long period if they don't fit properly. And of course, if they don't fit properly, there's a risk of exposure to the virus. And once we had established that that was a problem, there was a significant effort that went into assuring we had a range of supply and very proactive fit testing so people could always have the mask that they wanted or needed. I acknowledge that there must have been periods in the height of the pandemic when workers felt unsafe. I can certainly see from the subsequent evidence that was particularly the case with certain minorities. I wish we could have dealt with that. Future planning needs to make sure we can, but as I explained to you, for us it was a size issue, and when we saw it, we worked very hard to address it.
Thank you, my lady. Thank you, Lord Dighton.
Thank you.
Thank you, Mr Dale. That completes the questions we have for you, Lord Dighton. I'm extremely grateful to you. Since taking over this job, I've heard many dreadful stories, as you will imagine, but I've also heard some positive ones. And if I may say so, the team effort that you led to obtain vast quantities of PPE in extraordinarily challenging circumstances was one of the positive stories. So thank you very much for all that you did. Thank you also for highlighting the role of the manufacturers. It's not something I've heard too much about yet, and I think it was important to mark. So thank you for your help to the inquiry as well.
Thank you, my lady.
Very well, I shall return at 1:45.